All right, let's dive right in. Today we're talking about a concept that's absolutely at the heart of both nephrology and cardiology: ejection fraction. We're going to break down why this one number is so crucial for figuring out how your patients are going to handle hemodialysis.
It's the classic question we all face on the floor. You've got two patients, both need fluid taken off, but one of them, their blood pressure just tanks, while the other one sails right through treatment without a problem. So what's the difference? Well, it really all comes down to the heart's pumping power.
Okay, so ejection fraction, or EF, it's so much more than just a percentage on an echo report. For us, it's really a direct measure of the heart's reserve. Think about it this way. Dialysis is basically a state of controlled hypovolemia. We are intentionally pulling volume off the patient. So the EF tells us point blank, can this heart handle that stress? Can it keep up cardiac output when its filling volume, its preload, suddenly drops?
So, here's our game plan. We'll kick things off with what actually happens to the heart on dialysis. Then, we'll look at the two big types of heart failure you're going to see. After that, we'll connect the dots from theory to actual treatment. And finally, we'll zoom out to look at the bigger picture, what's happening beyond just the EF.
First up, the heart on dialysis. I want you to think of every single dialysis session as a stress test, a really rigorous stress test, aimed squarely at the ventricles. This image shows the chain reaction perfectly. We start ultrafiltration, which pulls off fluid. That directly lowers the preload, the amount of blood filling the ventricle before it pumps. Less preload means a smaller stroke volume. And since cardiac output is just stroke volume times heart rate, the entire system's output goes down. Now, a healthy heart can handle this, it can compensate. But a heart with a low EF, it's lost that ability. It has zero reserve left in the tank.
And that brings us to the two main characters in this whole story: heart failure with reduced ejection fraction, which we call HFEF, and heart failure with preserved ejection fraction, or HFpEF. Now, they both cause big problems on dialysis, but for totally different reasons.
So let's start with the one we all think of first, the HFrEF patient. Their EF is low, less than 40%. The problem here is simple. They have a weak, boggy pump. The ventricle just doesn't have good contractility, so it's super dependent on having enough preload to stretch those muscle fibers just to get a decent squeeze. The second we start dialysis and pull off even a little bit of fluid, their preload disappears, that already weak pump just gives out, and boom, they get hypotensive, and it happens fast.
Now, the HFpF patient, this is a totally different trap. You look at their echo, and the EF looks great, right? 50% or more. But the problem isn't a weak pump. The problem is a stiff ventricle. It's so non-compliant that it can't relax and fill up properly in the first place. That stiffness makes it incredibly sensitive to preload. So even a small drop in volume from dialysis means the ventricle fills even less, cardiac output plummets, and the patient crashes, all with a supposedly normal EF. So let's put it side by side, because this is the key difference. HFEF is the weak pump problem. It's an issue of poor contractility. HFpEF is the stiff ventricle problem. It's an issue of poor filling, or what we call diastolic dysfunction. Both patients are fragile on dialysis, but you have to know why to treat them right. Now, all this stress leads to a really dangerous complication called myocardial stunning. When we drop that preload and coronary perfusion gets too low during dialysis, it can actually cause temporary injury to the heart muscle. This isn't just a number on a screen, it's real damage. And if it happens over and over, that repeated stunning leads to chronic dysfunction. And here's the kicker. Even patients who start with a normal EF are at risk for developing a dialysis-induced cardiomyopathy from this. It's a huge deal.
Okay, so that's the theory. Let's get practical. How do we take this knowledge about EFN and actually use it at the bedside to keep our patients safe?
It really starts with a simple, powerful rule. The lower the ejection fraction, the slower you have to go with the ultrafiltration rate. It's that direct. Patients with a normal EF, they can usually handle moderate UF rates just fine. Your HFpEF patients, the stiff ones, are more sensitive, so they need low to moderate rates. But your HFrEF patients, the weak pumps, they have almost no tolerance. You have to use very low UF rates to keep them from crashing.
And this same logic tells us exactly which type of dialysis to choose. For your most fragile hearts, we're talking an EF under 30%, CRRT is the way to go. It's continuous, slow, and gentle. For those in that gray zone, maybe 30 to 40%, SLED is a great option. It's a nice middle ground. And for your stable patients with an EF over 40%, standard intermittent hemodialysis is usually tolerated pretty well. But I have to tell you, as critical as ejection fraction is, it's not the whole story.
It's just one piece of a much bigger and often missed cardiac puzzle.
Because if you've been doing this for a while, you've definitely had that patient, the one with the decent EF who, for some reason, just can't tolerate dialysis no matter what you do. It tells you there has to be something else going on.
And here it is. This is the big aha moment. A lot of the time, right ventricular failure is a way better predictor of dialysis intolerance than the left-sided EF is. Think about it. A failing right ventricle leads to systemic venous congestion. That pressure backs up everywhere. It not only keeps the left ventricle from filling properly, but it also creates back pressure on the kidneys, which just kills their perfusion. It makes the whole problem worse.
So let's just boil this all down to two final takeaways. Number one, the left ventricular EF tells you how fragile that patient is going to be to volume removal. It's your fragility index. And number two, it's the right ventricular function and the amount of venous congestion that will often determine the actual kidney outcome. You have to look at both sides of the heart.
And this quote really ties it all together perfectly. In hemodialysis, a low EF just kills the heart's ability to compensate when you pull off fluid, which leads to hypotension. At the exact same time, diastolic dysfunction from a stiff ventricle and venous congestion from a failing right heart are making it even harder for the kidneys to get perfused. Understanding this whole interplay, well, that's the real key to managing these incredibly complex patients.